this video, we'll discuss about tetracyclines. Tetracyclines are broad-spectrum antibiotics, and under broad-spectrum antibiotics, we have tetracyclines and chloramphenicol. In addition to gram-positive and gram-negative bacteria, they can also inhibit Rickettsia, Chlamydia, Mycoplasma, and some protozoans. So it is known as broad-spectrum. That is, it has wide range of activity. Tetracyclines are bacteriostatic drugs. That is, it inhibits the multiplication of bacteria. It does not kill the bacteria, but it inhibits the multiplication of bacteria. It inhibits the protein synthesis of bacteria by attaching to the 30S ribosome. Then it is obtained from soil actinomycetes, that is streptomyces. So tetracyclines is obtained from soil actinomycetes named streptomyces. So here we will see the classification of tetracyclines. Tetracyclines can be classified into short-acting, intermediate-acting, and long-acting tetracyclines. Short-acting drugs act for 6 to 8 hours, and under that we have chlortetracycline, oxytetracycline, and tetracycline. Then under intermediate acting, which acts for 12 hours, we have dimiclocycline and metacycline. Long-acting drugs act for 16 to 18 hours, and under that we have doxycycline and minocycline. The synthetic tetracycline analog is tigecycline. And under semi-synthetic tetracyclines, we have minocycline and doxycycline. How does the tetracycline enter into bacteria? It enters the bacteria by energy-dependent active transport. In case of gram-negative organisms, in addition to the active transport, they have passive diffusion also, and this occurs through pore channels. This minocycline and doxycycline are lipophilic drugs. So for them also, passive diffusion is also a mechanism by which the drug enters into the bacteria. So next we'll see the mechanism of action of tetracycline. So I've already said that it binds to 30S ribosomes, and after binding it will block the attachment of amino acyl tRNA to A site of the mRNA ribosome complex. Here in this picture you can see that tetracyclines this is the 30S ribosome and this is the A site. Here you can see the A site. I have marked the A site. So it will block the attachment of amino acyl tRNA. This is the tRNA I have marked here. So it will block the attachment of amino acyl tRNA to the A site of mRNA ribosome complex. And thus this peptide chain will fail to grow. This will lead to inhibition of protein synthesis. So this is the mechanism of action of tetracyclines. Next we'll see the mechanism of resistance. The mechanism of resistance is plasmid mediated and it is often inducible. Mechanisms include decreased accumulation, production of ribosomal protection proteins, and enzymatic inactivation of tetracyclines. So in case of decreased accumulation, the transport is less efficient due to efflux pumps. This efflux pumps, when it is present, it will throw the drug out of the cell. So there is decreased accumulation of drug inside the cell and that will lead to resistance. This doxycycline and minocycline are not effectively efflux. So the tetracycline resistant bacterial strains will respond to doxycycline and minocycline. Next is by the production of ribosomal protection proteins. So when this ribosomal protection proteins are produced by the bacteria, it will protect the binding site of ribosome, and thus the attachment of drug to the ribosome is prevented. In third mechanism, there is enzymatic inactivation of tetracyclines. So some enzymes are produced by the bacteria which will inactivate the drug. This will lead to resistance. Partial cross resistance with other tetracyclines and chloramphenicol is seen for this drug. Next, we'll see the antimicrobial spectrum of tetracyclines. Tetracyclines are active against cocci, most of the gram-positive bacilli, and gram-negative bacilli. All the gram-positive and gram-negative cocci, they were originally sensitive to tetracyclines, but now only few species like Streptococcus pyogenes, Staph aureus, and Enterococci respond to tetracyclines. Doxycycline and minocycline can be given for MRSA, that is methicillin-resistant Staph aureus infections. Most gram-positive bacilli like Clostridia and other anaerobes, Listeria, Corynebacterium, Propionibacterium, and Bacillus anthracis will respond to tetracyclines, but Mycobacterium, except Mycobacterium leprae, will not respond to tetracyclines. This Mycobacterium leprae will respond to minocycline. Then gram-negative bacilli like Haemophilus ducreyi, Calymatobacterium granulomatis, Vibrio cholerae, Yersinia pestis, Yersinia enterocolitica, Campylobacter, Brucella, Pasteurella, and many anaerobes are also susceptible to tetracyclines. Remember that Enterobacteriaceae is largely resistant to tetracyclines. You should remember the notable bacilli which are not inhibited by tetracyclines. These include Pseudomonas aeruginosa, Klebsiella, Bacteroides fragilis, Proteus, Salmonella typhi. So these are some important organisms which are not inhibited by tetracyclines. The minimum inhibitory concentration against anaerobes is relatively higher for tetracyclines. Then other organisms susceptible to tetracyclines include spirochetes like Treponema pallidum and Borrelia. All Rickettsia and Chlamydia are highly sensitive to tetracyclines. Then Mycoplasma and Actinomyces, Entamoeba histolytica and Plasmodium are inhibited at high concentrations. These are parasites which are inhibited at high concentrations of tetracyclines. Next, we'll see the pharmacokinetics of tetracyclines. Bioavailability is lowest for chlortetracycline and highest for minocycline. Absorption. Older tetracyclines are incompletely absorbed from the GIT. The absorption from GIT is impaired by food, calcium, magnesium, zinc, aluminum, iron, milk, antacids, and alkaline pH. The doxycycline and minocycline are completely absorbed irrespective of presence of food. Tetracyclines are widely distributed. It can cross the placenta and are excreted in breast milk. It can be deposited in teeth, bones, and reticuloendothelial system. Minocycline is highly lipid soluble, so it gets accumulated in body fat. Talking about the metabolism, the drugs are metabolized in liver and it gets concentrated in bile or excreted in urine. Doxycycline undergoes enterohepatic circulation. Excretion of tetracyclines is by both urine and bile. The primary route of elimination of older drugs drugs like tetracycline and demeclocycline include kidney. But in case of doxycycline and minocycline, it is very important to remember that the excretion of doxycycline and minocycline is through bile. So the safest tetracycline in renal failure is doxycycline. Minocycline can also be given, but the safest one is doxycycline. It is because it is not excreted through kidney, but it is excreted through bile. Next, we'll see the therapeutic uses of tetracyclines. Tetracyclines are drug of choice in some cases. We can see in which all cases tetracyclines are the drug of choice. First one is venereal diseases, that is sexually transmitted diseases. In case of chlamydial infection, 7-day doxycycline is given, which is equivalent to azithromycin given single dose. Then in case of lymphogranuloma venereum, also tetracycline is the drug of choice. Then granuloma inguinale. Here tetracycline is given for 3 weeks. So in sexually transmitted infections like chlamydial infections, lymphogranuloma venereum and granuloma inguinale, tetracyclines can be given as drug of choice. The other conditions where tetracycline is given as drug of choice include brucellosis, atypical pneumonia, cholera, and rickettsial infections. In brucellosis, doxycycline 200 mg per day plus rifampicin 600 mg per day is given for 6 weeks. Here it produces rapid symptomatic relief. Then in case of atypical pneumonia produced by Mycoplasma pneumoniae and also in psittacosis, we can give tetracyclines. In case of cholera, it will decrease the stool volume and limit the duration of diarrhea. Doxycycline 300 mg single dose is given. In case of rickettsial infections like typhus, Rocky Mountain spotted fever and Q fever, it will respond dramatically to tetracyclines. Tetracyclines can be given as drug of choice in case of plague and also it is given for local application. In case of bubonic and pneumonic plague, it is preferred for mass treatment of suspected cases during epidemics. Except in eye, topical use is not recommended. Minocycline is used for swimming pool granuloma. Minocycline sustained release microspheres are used for subgingival administration in dentistry. So now we have seen tetracyclines used as drug of choice. Next we'll see tetracyclines used as second choice drugs. It is given for tularemia, actinomycosis, tetanus, anthrax, listeria, nocardiosis, syphilis, gonorrhea, yaws, and acute treatment and prophylaxis of leptospirosis, relapsing fever, and Lyme disease. Other uses of tetracyclines include urinary tract infection, community acquired pneumonia, chronic intestinal amoebiasis, chloroquine resistant falciparum malaria, acne vulgaris, and pleurodiscs. Doxycycline can be given for filariasis where it kills the symbiotic Wolbachia bacteria. So this is a symbiotic bacterium which lives along or which survives along with the Wuchereria bancrofti. So to kill the symbiotic bacteria, we can give doxycycline. Then demeclocycline is given for SIADH and hyponatremia. So now let's see the adverse effects produced by tetracyclines. It can produce irritant effects and in GIT it is manifested as nausea, vomiting, diarrhea and peptic ulcer. If the drug is given intravenously, it can cause thrombophlebitis of the injected vein. Then tetracyclines can produce organ toxicity. First is kidney damage. It can precipitate kidney failure in patients with renal disease. So in that case, doxycycline and minocycline are safe. This is because they are excreted through bile. Then demeclocycline can produce nephrogenic diabetes insipidus. Fanconi syndrome can be produced by outdated and degraded tetracyclines. This is due to the degradation products. These degradation products include epi-anhydro and epi-anhydro tetracyclines. It can produce damage to bone structures and teeth. This is because of the chelating property of tetracyclines. In teeth, it can produce permanent discoloration, that is permanent brown discoloration. This is due to the chelation of the drug with calcium. And this chelate deposit will produce permanent brownish discoloration. And this is especially seen in children less than 8 years of age. So the drug tetracycline is contraindicated in pregnancy because it can produce discoloration and ill-formed teeth in children. In case of bone, it can depress the bone growth. Tetracyclines can also produce hepatotoxicity. This can lead to fatty liver and jaundice. And in that case, oxytetracycline and tetracycline are safe. Other drugs can produce hepatotoxicity. Other side effects produced by tetracyclines include phototoxicity, which is produced by dimethylcycline and doxycycline and can result in onycholysis and pigmentation of nail. Then vestibular toxicity. Minocycline can produce ataxia and vertigo, but it is reversible. Doxycyclines can also produce pseudotumor cerebri. This is due to the increased intracranial pressure and it is seen especially in young infants. Other side effects include hypersensitivity reactions and superinfections. Superinfections with Candida, resistant staphylococci, Proteus, Pseudomonas, and pseudomembranous colitis produced by Clostridium difficile is also seen with the use of tetracyclines. Now we'll see the contraindications and precautions to be taken before the use of tetracyclines. So tetracyclines are contraindicated in pregnancy, lactation, hepatic and renal insufficiency, and also it is contraindicated in children less than 12 years. Precautions to be taken are it should not be used beyond the expiry date, because we have already seen that the degradation products can produce Fanconi syndrome. Then do not inject tetracyclines intramuscularly or intrathecally. Now we'll see the drug interactions of tetracyclines. Antacids containing aluminum, calcium, magnesium and iron containing preparations and also the bile acid sequestrants will decrease the absorption of tetracyclines. Then enzyme inducers will enhance the metabolism and thus will decrease the plasma half-life of tetracyclines. Do not mix tetracycline with penicillin because it will lead to inactivation of the drug. Also, tetracyclines will interfere with the bactericidal action of penicillin. Then anticoagulant therapy, that is when a patient is on anticoagulant therapy, dose adjustment should be made. Then tetracyclines can lead to oral contraceptive failure. When it is given along with diuretics, it can increase blood urea. Now we'll see the difference between doxycycline and tetracycline. Tetracycline has poor oral absorption while doxycycline has got good oral absorption. Tetracycline is a short acting drug while doxycycline is a longer acting drug, so it can be given once daily or twice daily. Doxycycline is safe in renal failure, but tetracycline is not safe because tetracycline is excreted through kidney while doxycycline is excreted through bile. Then doxycycline will produce less diarrhea and superinfection, but these are markedly seen with use of tetracyclines. There is no food interaction present with doxycycline, but there is food interaction with tetracyclines. Doxycyclines are more phototoxic than tetracycline. Now we'll discuss about minocycline and tigecycline. Minocycline is a most potent agent and it has got 100% bioavailability. It is a highly lipid soluble drug and satisfactory levels are achieved in CSF. So it is preferred in meningococcal meningitis as an alternative to rifampicin. Minocycline causes reversible vestibular toxicity. Then talking about tigecycline, it is a derivative of minocycline and it has got higher affinity to the 30S ribosome and is more potent than minocycline. It has got broadest spectrum bacteriostatic action because it is also active against tetracycline resistant organisms. Then Pseudomonas and Proteus, they are inherently non-responsive to tigecycline. The mechanism of resistance like efflux pump and ribosomal protection proteins are not effective against tigecycline. This is the pharmacokinetics and uses of tigecycline. Tigecycline has got poor oral absorption, so it is given as IV infusions. Then it is widely distributed in the body and the T-half is 36 hours and it is eliminated through bile. So no dose reduction is needed in renal failure. The uses of tigecycline include MRSA, MSSA, that is methicillin resistant Staph aureus, methicillin sensitive Staph aureus, penicillin resistant pneumococci, then life threatening skin and soft tissue infections, intra-abdominal infections, and in all those cases 100 milligram intravenous loading doses followed by 50 milligram 12 hourly for 5 to 14 days. This is the dose of tigecycline. It can also be given in hospitalized patients of community acquired pneumonia, but it is not recommended for hospital acquired or ventilator acquired chest infections. The adverse drug reaction of tigecycline include nausea, vomiting, diarrhea, photosensitivity, and superinfections. Also, these are contraindicated in children and pregnancy. So that is all about the discussion of tetracyclines. Thank you.